Hi. Are we having a risk assessment? Can we prevent the pressure ulcer? Can you know which patients already in risk for a pressure ulcer? If I give you 10 patients and you already have only 5 offloading mattresses, for whom you will give and based on what? This what we will discuss today presentation. Stay with us. This is Abdulkareem Blasi. Risk assessment. From its name, it's apart from risk identification tools or abilities that will make you able to catch the people in risk for something. Here we are talking about in a patient. They are much more in risk to develop pressure ulcer. How I will help you to know whom are they. The most well-known tools all over the world, it's what Dr. Barbara Braden already invented, and it's well known in the overall globe known as Braden scale. And here we will discuss Braden scale tool, items, way of classification, and what are the other tools already applied. We are talking about a Braden tool. We will discuss here mainly 6 points, and each point already give us a scale from 4 categories, except 1 point or only give us 3 points. What are these points? The first one is the sensory perception. What is the sensory perception? From its name, we will evaluate the patient based on his or her perceptions. What are these perceptions and how I will put the patient from 1 to 4. When we are talking the Braden, whatever the rest below is low, the patient in high risk to develop a pressure ulcer. When he getting in higher, the chance for developing the pressure ulcer will be reduced, but always there is a chance to develop the pressure ulcer. Come back again here for the sensory perception. We are talking about points ranged from 1 to 4. 1 is completely limited, and 4 there is no environment. From my experience, even when I'm dealing with caregivers at houses, there is no difference or no hardness for the people to get agreed if the patient was on 1, which is completely limited, or 4 with no impairment, but they have getting some differences in the points in the middle. What's the meaning of the best condition? What's the meaning of no environment? No environment means the patients respond to your verbal commands. Speak with your patient and look for his response or her response. If he has no sensory defects, the patient able to feel, communicate the pain, communicate the discomfort. How I teach it for the nurses, there are 5 sensory perceptions. The vision, auditory, tactile, smell, and taste. When the patient already had these 5, most probably he would be in no impairment. If he had 5, he will get 4 in the Braden. But when he will be dropped to be slightly limited? Based on the Braden guideline, say that the response to the verbal commands but not always communicate in a discomfort way, or need to be turned, and he has some sensory environment which limits ability to feel in pain or discomfort in one or two of his extremities. In another word, you can speak with your patient, and the patient already had the sensories, but he had some limitations in these sensory perceptions. How I will transfer this to the practice? If the patient unable to move one or any of his extremities, he will be on the slightly limited. I cannot believe someone post-op and he's already had no impairment. It's very hard for me to think about a patient with a diabetes come to the hospital with a retina cataract and he's already had no impairment. So by default, he will lost some part of his sensories. He can communicate with you, but there are some limitations in dealing with this communication. And be sure that the patient already in hospital had some difficulties. Very limited, and here we will start to transfer our actions to be much more focused for the critical care patient. Response only to the painful stimuli. If there is any painful issues that you are making for the patients, cannot communicate with the discomfort, and is always complain of restlessness, and there are possibilities that he feel the pain but unable to communicate with you. And always tell the nurses that maybe he had only one sensory still with him. Maybe he's just only able to hear you, or maybe to smell, or to see, but he doesn't have all of them together. Just maybe have one or two of these sensory perceptions. The worst scenario when the patient is completely limited, unresponsive. There are some signs and symptoms of moan, fidge, grasp. Level of consciousness is low. Maybe from the sedation. Please don't mix between Braden scale and the glycocoma scale. Two different scales, but there are some overlapping because they are still evaluating same patients. So there are some issues. In the Braden tool, it's written like the patient limited ability to feel pain over most of the body surface, but I transfer it here for my nurses that the patient may be feeling the pain, but you don't recognize that. The second point here is the moisture. Moisture. I'm always have been learned that the moisture is something good. Even in some advertisements about the skin cream, they say that give you the moisture for your skin. Then why the moisture here getting something I should focus on? In fact, we are here going also to describe the skin moisture over bony prominence. Of course, the skin have some normalities of having moisture, but what my concern here is skin over the bony prominence. And the scale also comes from 1 to 4. rarely moist. And this is the good point. Rarely moist, and this is the good point. We are looking here to see the skin over the bony prominence. Please focus on the sacral area. This should be dry and not contaminated. And even if contamination happened, maybe due to the diaper or the patient on the bedridden condition, he had it for one time only. Also, the patient will transfer to be lower place, lower category on the moisture by making the ecogenal moist. Ecogenally moist means it can happen, or in our term, this is happen one time every 12 hours. First one, even the patient able to go to the bathroom, go to the WC. Oh, this is not happen at all in last 24 hours, or even if it's happened once, then the patient will get 4. If the patient already getting 12 hours had one time of contamination of the urine or stool on the perineal area, it will be ecogenally moist. Very moist means that the skin is often, but not always moist. Often, that means the frequency of contamination or exposure to the urine or stool or moisture over the skin is getting higher. It happens one time each 8 hours. Consistently moist. Consistently moist means the skin is kept moist almost by the patient getting in very worst condition, stool, urine, whatever. And this will make the skin much more weak, fragile, and easy to get the pressure ulcer. However, in the 4th week, we will differentiate between the pressure ulcer and incontinence-associated dermatitis also. Patients with high moisture of the skin over bony prominence will be in higher risk to develop, yes, pressure ulcer. However, one of the frequent questions come always to me that, what about the patients with a Foley's catheter? It's not my issue if the patient was with a Foley's catheter or condom or fecal device. Is the skin had contamination with the moisture? Yes, go for this category. No, then the patient's skin is safe regardless of the other interventions that should be done for him. Go for the following points, which is activity. What is the activity? We are describing here the patient's current degree of activity, and it's again from 1 to 4. The most repeated question about differentiation between activity and the following point, mobility. Stay with us to know the answer. Activity also consists from 4 points. The first point, that the patient, when he will get 4 over 4, when the patient already able to ambulate, walks frequently, walks outside the room, at last 2 times per day. This is based on the Braden. And every 2 hours, he had some types of movements in the room. And this will give you an indication that the patient already walks frequently, and he's already getting the ambulation 4/4. Walks occasionally when the patient walks during the day, but for the short distance. He's able to go from this point to this point, but with a less frequency each day. Maybe he will be in need for some assistance. There are so many reasons that will make the patient, even physically is able to walk, prefer to stay. Maybe the medication, maybe his psychological condition. What's important for me here, what already happened with this patient. We don't evaluate the patient's ability to move, rather than what he's doing already on your duty. The patient will get 2/4 on the activity when his ability to walk transfer to be limited or not exist. Either the patient's unable to carry out his body weight, stand up, or for any other reasons the patient stuck on the chair or the wheelchair. In this way, Braden call it chair fast. Bed fast, which the patient already stay all the time on the bed, unable to move, cannot move because of the medical issues. For me, the patient already stay on the bed. He will get only 1/4.